I just want to say that both Colin and I are very excited to have joined the Doheny family, and the Pasadena office is an amazing place. There's all kinds of imaging equipment thanks to Voss, and we look forward to doing a lot of collaboration and projects and working with your fellows, and I think we can really bring a lot and grow bigger by joining our oncology centers into a UCLA Department of Ocular Oncology. So I have no relevant disclosures. I want to first acknowledge Dr. Mondino for all of his support for our oncology program that we began in Westwood. And now I want to thank Dr. Sada for his support for the Doheny side of ocular oncology. And of course, Dr. Stratzma, who has been my mentor since before I started Jules Stein, when I had the opportunity to be interviewed for the position. So I greatly appreciate that. So I want to share with you a story of how change can be made in a field that is traditionally quite rigid and conservative, and that's the field of ocular oncology. And it is possible to make changes in this even though you have to butt against convention and go against authorities. And I'm going to share a little bit about how ocular oncology has significantly changed at UCLA. So I'm going to also share with you the goals of our oncology center, touch on a little bit about why ocular oncology is so slow to progress, and some key bits of evidence that might help us think in a more modern way, a few things that UCLA has added to the field, and then some thoughts for the future. So when a patient comes to UCLA, we have three main goals. We want to save their life, we want to save the eye, and we want to do everything possible to save the sight. So how can we save a patient's life? Well, you think it's obvious, but first we need to make the correct diagnosis. If a patient doesn't even know they have cancer, there's nothing they can do about it. There's nothing they can be proactive about or see a general oncologist to review their general health. And also, we need to give patients information. And I'll talk a little bit about intraocular biopsy for molecular prognosis and how that can give patients information on how serious or less serious their cancer may be in terms of the risk for spreading for metastasis. And it's important to have our patients work closely with oncologists. And why is that? Well, we just heard from the past talk that there are a number of new therapies and targeted therapies that may help prolong survival. And if a patient doesn't have a doctor who knows what's going on or has their pulse on the latest treatments, they can't properly be screened, and I find that our patients stop getting imaging studies and systemic surveillance, and this is really not the way to be proactive. We need to have our patients be one step ahead of the cancer before it comes to the rest of their body. So let me just share with you a case. This is a patient who I saw a few months ago, but saw their retina specialist and then saw a few other retina specialists, and she described to me that people were scratching their heads, they weren't sure what to do, and so she was told to come back in another few weeks. So she found her way to our clinic, and this patient has a melanoma. So it's very important to make this diagnosis, and these are not necessarily straightforward cases. Here's a lady that had a vitreous hemorrhage for many months, for at least 9 months, that she told me that it was being observed and it started to clear. And she had this persistent area that blocked entirely to the fluorescein angiogram. And when we saw her, she was told that she would be seeing us just to make sure that she didn't have anything else wrong, but there was a 99% chance that this was nothing. So she has a mushroom-shaped lesion on ultrasound, and this patient had a choroidal melanoma. Fortunately, her prognostic test result was excellent, and so she has a low risk for the cancer spreading. So how can we save the eye? Well, I think that when we talk about a nucleation is very rooted in the traditional approach to treating uveal melanoma. And I'll talk a little bit about the COM study, but before the COM study, and even now, there are some centers that recommend a nucleation in order to help lower the risk of mortality in this cancer. And another thing is that large tumors, many which you may not believe, can actually be treated with brachytherapy, and we can save the eye. One of the tricks that we use is intraoperative ultrasonography. And this is something that Dr. Stratzma always had in place. So when I arrived at the Jules Stein Eye Institute, we were already doing intraoperative ultrasonography. And we reviewed all the patients where we had to move and reposition plaques, and we found that that certainly using ultrasonography to more accurately place our plaques results in less cases of treatment failure. Another way we can save the eye is to observe small lesions carefully. Many people come with a suspicious lesion that's slightly elevated, and we're told that this is probably a nevus, and the patient goes home. But it's important that these patients be monitored because there's always a small risk that a nevus or a suspicious elevated lesion may transform. And certainly people who have been treated must be monitored carefully because there are treatable side effects that can happen even after brachytherapy. This is a patient who is a physician, and he came in and had this flat nevus in the eye, and I said, well, there's a very low risk that this could change, but I think we should still see you in a year. So 6 years later, a few months, actually a week or so before he came in, he sent me an email saying, I noticed my vision getting worse over the past few months, and I just have been in denial, so now I'm going to come and see you. Well, he had a very large melanoma and with very poor vision and had to be enucleated. So these things do happen even though they're rare, so it's important that patients be monitored. And this is just our work that we did showing that when we do intraoperative ultrasonography to more accurately place our plaques, we have lower failure rates than in the collaborative ocular melanoma study. And I feel very proud that because of Dr. Strassman's tradition of excellence and of the utmost quality of care that we continue to do this. And there are many other benefits of using ultrasound in the operating room. One is sometimes tumors grow between the date that you see them in clinic and when you actually treat them. And you can actually remeasure and account for that, recalculate, add a few hours or an extra day to the treatment, and the patient will be adequately treated. So how can we save the vision? The treatment of small melanoma is another very controversial subject in ocular oncology. There are many clinicians, excellent ones, who feel that if the melanoma is small, that it can be watched, because if we try to radiate a small melanoma, the patient will go blind. And many small melanomas actually are found in the macula. Why? Because usually those small tumors start to affect the vision very early, and so they're discovered in the macula. And if we just leave them and monitor them and the vision slips a little bit, there can be problems. And I think at our center, we think it's very important that if a patient has a melanoma, even though it's small, it should be treated. And other ways we can save the vision are to limit the amount of radiation exposure up front. And I'll get into that in a little bit more detail about our use of silicone oil. And there are many other diseases that affect an eye that has a tumor in it. Like a patient who doesn't have a melanoma, they can develop cataract, they can have macular degeneration, they might need glaucoma surgery, and they can develop retinal detachment. Here's an example of a lady who was very nervous about undergoing treatment, and she had seen a few people, and someone suggested that she be enucleated. Another person suggested that she could only be treated with proton beam therapy, and she had a tumor that was only 1.8 millimeters in height, and her vision's decreased. It's 20/40. And this is her fluorescein angiogram. It shows hyperfluorescence, which we usually see a sign of activity of the tumor, and there's some window defect underneath from her retinal detachment. And here's an OCT through the tumor, and then it shows actually another little area adjacent to it that shows up in the OCT. So she underwent brachytherapy treatment, and 2 years later, her vision's 20/50, and she's doing very well, and she's very happy with her vision. And this is an example of how patients are not plunged into blindness after their treatment if we can get the tumor small. Well, you may say, well, this is only 2 years, so I'll show you another case. This is a lady who presented within a year or so after I started. She had a tumor in a very difficult location, which is in the nasal macula, but again, a small melanoma, 20/25 vision. And 8 years later, here she is. Her vision's 20/40, and she's, again, doing very well. Here's her OCT showing that she doesn't have any atrophy or retinal edema at the macula. Here's an example of a patient with a large melanoma. And this is I share this example because we can treat some of the complications that can happen even after a patient undergoes radiotherapy. So this patient had a phacoemulsification, intraocular lens placement. We did a vitrectomy, put silicone oil in for radiation attenuation. And at post-op month 2, this is what the eye looked like. What are we going to do? The vision is hand movements. Started off, everything seemed good. So would we enucleate this eye? Would we just say everything is lost, there's nothing we can do? No. We can fix this. This is like a PVR detachment. So this patient had a retinectomy. We removed the subretinal fibrosis and put in oil, and is doing, this is just 2 weeks afterwards, but vision improved, and the patient is doing very well. So these eyes are salvageable. We shouldn't just put them out to pasture if they develop complications that we would normally treat in a patient who doesn't have a melanoma in their eye. So why is it that ocular oncology is so slow to progress? I think there are many reasons, but you might find it surprising that the diagnosis and management of uveal melanoma has not changed for decades. Perhaps this is because melanomas of the eye are rare. Most ophthalmologists may not see any melanoma in their career because they're extremely rare. There have been no new innovations. Brachytherapy is still hailed as a new treatment and an eye-saving treatment for melanoma, although we've had it for about 30 years. The Collaborative Ocular Melanoma Study sort of established iodine-125 brachytherapy as an excellent way of local tumor control, but nothing has changed since then. Because the Jules Stein Eye Institute under Dr. Strasma was one of the major centers on the West Coast, I do want to talk a bit about what this study showed. The reason for the Collaborative Ocular Melanoma Study, one of the reasons that it was necessary to resolve a controversy between a nucleation or eye-saving brachytherapy. There were people on both sides. Some individuals felt strongly that the eye had to be enucleated in order to save the life of the patient, and there were others who believed the opposite. And what was discovered was that in the medium tumor trial, which is the most often referenced, is that there was no difference in mortality between enucleation and iodine-125 brachytherapy at up to 18 years. So both treatments work, but patients still succumb to metastatic disease. Now, even though the Collaborative Ocular Melanoma Study is still a benchmark, there are some details that you may not know about of the COM study that many centers still use that are truly archaic, and I'm just going to point out a few of them. So did you know that if you had a melanoma that was 2 millimeters high, according to the COMS criteria, you would give as much radiation as you would to a tumor that was 5 millimeters high? Well, maybe that's why people lost their vision when small melanomas were treated. At our center, we have not been treating to 5 millimeters. We treat to the tumor height, and this is certainly since the time I've been at the Jules Stein Eye Institute, but I have many colleagues who routinely treat small melanomas to 5 millimeters. That's a lot of additional radiation. Another thing is the definition of a large tumor. If your melanoma was greater than 10 millimeters in height, according to the COM study, your eye would be enucleated. So there are many centers that use 10 millimeters as an arbitrary cutoff for not treating the patient and offering enucleation instead. And the same goes for greatest basal diameter. And certainly because papillary or peripapillary tumors were excluded in the COM study, many centers recommend enucleation as a good treatment option for treating peripapillary tumors. These tumors are treatable by plaque, and there are lots of ways to get around saving the eye and still killing the melanoma. So in contrast to other areas of ophthalmology, in cataract surgery we heard about how our old treatments have evolved to phaco, and now we're revisiting, we've gone full cycle, and we're looking at sort of extra cap fast techniques in glaucoma. There's all sorts of new ways and techniques of lowering the pressure, and retina surgery is certainly an area where there's been tremendous change as we move through the decades. But in melanoma, it's the same old treatment. Nothing has changed. So let's think about some misconceptions that you may hear in the back of your mind. Enucleation is the best strategy to lower the risk of metastasis. True or false? False. Good. You should all be shouting that in unison, because we think that by the time the melanoma is diagnosed in the eye, that there are some micrometastatic cells that have already spread and perhaps are dormant in the liver. The more you manipulate or stick needles into a tumor, the greater risk you have of spreading the cancer. A lot of people think this is true, but we have shown that this is not true, and I'll show you some data as well. If the eye develops a cataract, you should just observe. That eye's been through hell and back, don't touch it. Well, of course that eye will not see if the cataract's not removed, and I know that Dr. Miller and his group has looked at our patient outcomes in treating cataracts after melanoma, and they do very well. If the pressure goes up, do your best with topical drops. If the pressure's hovering in the 20s, don't touch that eye. Well, I know a glaucoma specialist, both Doheny and Stein, don't view this, and we do invasive glaucoma surgery on these eyes if the tumor is well controlled. I don't know what's going on. I don't know if it's growing, the vision is bad, there's rubiosis, we should just enucleate. I don't know what it is, let's enucleate. So these are some of the thoughts that still are very pervasive today, but there's other ways around them. So reasons why, well, I think that ophthalmologists are really no different than other physicians. We don't want to hurt the patient. And in melanoma, we know so little. Why does the cancer spread to the liver? We still don't understand that. And why does it happen? Why can it happen so many years later? So we don't want to hurt patients. So we're very tentative to do something invasive or even move away from traditional approaches because we feel most safe and comfortable with what we learned in residency. And then there's fear of establishment. There's some very senior people in the field of ocular oncology who are very strong and very opinionated. And if you want to change things or alter management, you are met with much resistance. It's very difficult to get papers published in ocular oncology, so you have to pick your friends carefully and your reviewers too. And cancer in general. I think ophthalmologists may not be used to dealing with life and death and having these discussions, very frank discussions with patients. And there's great fear of doing something that might put a patient's life at risk. So let me share with you two basic bits of data that we already know that may influence our thinking to a more modern approach. I already said that in the COM study, we found that there was no difference in mortality between plaque and enucleation. So an old-fashioned interpretation would be, good, so plaque surgery doesn't put the patient at risk. Let's radiate tumors and not remove eyes. But a more modern interpretation would be, so it doesn't seem to matter what you do. Patients die of their cancer regardless of what we can do to their eye. So let's get more comfortable treating the eye in other ways that might help improve sight and their quality of life. And you may or may not know this, but there is a marker that's associated with high risk of metastasis, and this is the reason we do fine needle biopsy. So monosomy 3 is the strongest risk factor. This is a loss of one copy of chromosome 3 in the tumor. And so the old-fashioned view of this would be, well, if you have that in your tumor, that's too bad. You're fated to a metastatic outcome. But the modern interpretation of this may be that, well, look, it's actually the tumor biology that determines whether a cancer will spread. It's not what we do to the eye. So we're not going to increase risk by putting a needle in the eye or doing a vitrectomy surgery. Let's treat whatever the underlying problem is. So I want to share with you two things that I'm very proud of that at our center we have helped move the field a little bit forward. Fine needle biopsy met with much controversy, but we do this to get information to patients. We now can tell a patient if they have a low risk of going on to get metastasis or a high risk. And we know this is safe. And we have some new techniques for getting this information in very small tumors. Instead of saying, oh, it's too dangerous to do a biopsy in your small tumor, we have other ways. Here's a patient that has a small melanoma, and this is a paper looking, we can actually get transscleral biopsies from this, but a better approach is to use the 27-gauge vitrectomy. And one of our fellows, Aaron Nagel, presented at Research Day these findings, but this is let's see if this works. This is just a video of taking a biopsy. So we use a 27-gauge vitreous cutter, and this is very limited vitrectomy. You go straight into the melanoma, and you poke through the retina. You can aspirate back a little bit of sample, and then you reflux it into a receptacle, and you can send it for DNA and RNA testing. And in a few weeks, you can know the patient's metastatic potential. And what is this with silicone oil? I'm sure many of you have heard about this, but what silicone oil does is it reduces radiation to non-tumor parts of the eye, and it reduces radiation retinopathy, and it improves vision in large tumors with 1.5 years of follow-up. So when you treat a melanoma, you put a plaque on the eye to cover the tumor. Some radiation, in addition to treating the tumor, affects the healthy tissues. But if you put a vitreous substitute in the eye, you can actually limit some extraneous radiation from affecting the healthy tissue. And here's just a slide showing data in large melanomas where we use the most radiation. And in these patients, they often don't have many years left of survival. So these are results at about a year. And you can see on the left, there's far more patients who have good vision because the red bars represent using silicone oil. And you can see that as we look at the poor vision outcomes, which often is the fate in these large tumors, there are far fewer patients who have worse than 2200 vision or LP-NLP vision. So this is, I think, a very helpful way that we can reduce the radiation, improve vision for patients up front. So just to wrap up, what can we look forward to in the future? I think we need to question the traditional approach. There's so much technology and new things that we can adopt to help our patients see better and save their eyes. We need to be comfortable with being criticized. Well, certainly I'm used to it now, but it can be very difficult to sort of break from what's traditionally acceptable. And then we need to reevaluate what we're doing. Are we using our techniques and external biopsies? Now we do internal biopsies. Are we changing what we're doing? Another thing that we're doing in our office is we're taking plaques out in the office. We don't take patients back to surgery anymore. And I think we have to always come back to the patient. Is this helping them? And I tell you, patients greatly appreciate you not only saving their eye, but also managing other things that can give them better sight. Thank you very much.